Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I'm your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts from around the globe and around all aspects of drugs and addiction. Today's episode is sponsored by ISAC, the International Academy on the Science and Impact of Cannabis. Visit their website at isac1.org, IASIC1.org, to follow the science on marijuana. Friends, fentanyl is plaguing America. There is no safe drug supply unless it comes from a legal pharmacy. If you are around anyone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. Hello again, High Truth listeners. Get ready for a SAMHSA conversation. I'm your host, Dr. Ronit Lev. SAMHSA stands for the Substance Abuse and Mental Health Services Administration and is an agency within the U.S. Department of Health and Human Services. Mental health and addiction health very much overlap. Of the 20 million people who have a substance use disorder, about half, 50%, also have mental illness. Of the 47.6 million adults with a mental illness, about 20% also suffer from addiction. SAMHSA leads the public health efforts to advance the behavioral health of our nation. The government agency was established in 1992 by Congress as part of a reorganization effort. In that reorganization, SAMHSA took the treatment function for mental health and substance use disorder, while the research part was separated and led by NIDA, the National Institute of Drug Abuse, and NIAAA, the National Institute of Alcoholism and Alcohol Abuse. Both NIDA and NIAAA are under NIH, the National Institute of Health. SAMHSA is a powerful agency with a 2023 budget of $10.7 billion. That's a lot of money. And the funds are geared toward mental health, substance use prevention, treatment, and health surveillance. And with that, let's hear our question of the day.
Hello, Dr. Lev. Thank you for the work you do here in San Diego County to keep our communities safe. My name is Marla Kincaid, and I have the privilege of facilitating the San Diego County Substance Use and Overdose Prevention Task Force, formerly the MESS Strike Force and the Prescription Drug Abuse Task Force, which was established in 1996. My question for you today is regarding funding. Funds go out either for mental health or for substance use or drug treatment and prevention programs. Sometimes these fundings happen within silos. How can SAMHSA encourage collaboration between substance use disorder programs and behavioral health programs?
Marla, thank you for your question, and thank you for all you do for San Diego County in facilitating interactions between diverse agencies, all for the good of the citizens of San Diego, making San Diego healthy and a place to live. So thank you for all that and your question. And to answer your question, I reached out to the tippy top of U.S. government for all issues on mental health and substance use disorder treatment, and that would be the head of SAMHSA, Dr. Miriam Delphin-Rittmon. Marla, I'm going to integrate your question into my conversation with Dr. Delphin-Rittmon, who is currently the Assistant Secretary of Mental Health and Substance Use in the U.S. Department of Health and Human Services and the administrator of SAMHSA. Before heading SAMHSA, she had an extensive, accomplished career, including serving as commissioner of the Connecticut Department of Mental Health and Addiction Services. To learn more about Dr. Miriam Delphin-Rittmon, check out the High Truth show notes. Dr. Delphin-Rittmon, welcome to High Truths.
Thank you. Thank you so much for having me, Dr. Lev.
I am so excited to have you here. And I have so many questions to the director of SAMHSA. What is SAMHSA? Mental health, substance use disorder, health equity, opiate disorders, marijuana, and the overlap of everything. So I hope I get to everything. But let's just start with what is SAMHSA? Tell us about the organization.
Okay. So SAMHSA stands for the Substance Abuse and Mental Health Services Administration. And, we are comprised of, we have 4 centers. So the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Center for Substance Abuse Prevention, and the Center for Behavioral Health Statistics and Quality. And then we also have several offices. So we have our 988 coordinating office. We also have our Office of Behavioral Health Equity. We also have our Office of Fiscal Resources. But essentially, you put all that together, and our work is about, addressing the behavioral health of the nation from a prevention, treatment, recovery, harm reduction perspective. And those are many of the key areas of our work.
That is important to all of us, probably in all our lives. So a very important office, making a big difference in our nation, where we really need it these days. What about the word? SAMHSA has the word abuse in it, and we're trying to change the name. Are you working on that?
Language does matter. It does matter. And so we are looking at the abuse, the word abuse in our name. And we are looking to make some changes there. Of course, that would require legislative action. And so we are, looking to put forward a recommendation there. We believe the word abuse is stigmatizing. And we know stigma, you play that out, and it could ultimately impact people's help seeking or the willingness to access services. So we are looking to change the abuse to use.
Right.
And so would need legislative action for that, though.
An act of Congress. So you're waiting on that.
Yes.
Let's talk mental health. We definitely have a serious mental health crisis in our country. As an emergency physician, that's probably my number one issue. People would be surprised, but mental health crises are number one things that we see in the emergency department, and patients wait for days and months for an available bed. So let me first just ask you, why is this? Is it more volume patients, decreased resources, drugs, all of the above?
It's a complex question, and it likely is some combination of all of the above. We know certainly since the pandemic, we have seen increased challenges around behavioral health. We see increased rates of anxiety and depression among young people. We've seen our overdose rates continue to increase. We've seen suicide rates increase among some age groups. So it certainly is a challenging time. I think all of that potentially contributes to what we're seeing happening within emergency departments. Some of our goal there and some of our work, and I'm so appreciative of the president and the Biden-Harris administration's leadership there, because we've received increased resources to be able to help further build out both crisis services and supports, but then also to expand community-based services and supports so that an individual can get connected to care, ideally before they're in crisis. And all of that can help to take some of the pressure off of the emergency departments. That certainly is one of the things that we're aiming for.
Is there any talk about bringing back long-term psychiatric beds that were closed during the Reagan era? Having those patients in the emergency department affects not just those patients that, being in the ER for months with a mental health crisis is probably not the ideal place, but it also affects people waiting to come in. I had a friend die in the waiting room because there's no beds, and he was in chest pain for an hour because there's no beds available. So it's a crisis all around for our society. So I was wondering if there's any talk about bringing back those type of beds.
We're actually hearing the opposite, that in fact, sometimes for some individuals, being in an inpatient setting for a long period of time, that can be traumatic. It disconnects them from the daily rhythms of their daily life. And so increasingly, actually, what we're seeing states and communities talk about is increasing community-based care. So treating people at the lowest level of care possible, given what they're experiencing, so appropriately connecting them to the lowest level of care possible. And so what we're seeing is things like stabilization centers begin to pop up more, or crisis receiving centers. That can be an alternative both to a crisis bed or to a person going into an inpatient setting, because ultimately with a stabilization center, a person may be stabilized at that site and then connected to other outpatient community-based services and supports. And we know that there are acts that, for example, the Olmstead Act talks a lot about that, about treating people in the least restrictive, most integrated community-based setting. And so certainly that's one of the areas that we're looking at and the area we're focused on. One example I'll provide is, our community-based, our CCBHCs, so Certified Community Behavioral Health Clinics. We now have 500 of them around the country. And what they're geared towards is connecting people to community-based care, whether they're grappling with mental health challenges, substance use challenges. 24-hour crisis support is provided as well. And again, there are 500 of them across the country, and we are looking to continue to scale those up as well.
All right. So those are some of the solutions that you're working on in mental health. Anything else we should know about that SAMHSA is working on with the mental health challenges of our day?
Absolutely. So last July, we transferred the 10-digit suicide prevention crisis lifeline number. We transferred that to a 3-digit number, 988. And the thing that I'm really excited about with 988 is if a person is in crisis, whether it be for mental health or substance use or some other suicide-related crisis, they can call, but they can also text or chat. And I think that's the real, important piece here. A person can call, text, or chat 988. If they're chatting, what they would do is they would chat to 988lifeline.org. And they'll be connected to a trained, compassionate counselor who can talk with them and address whatever they're dealing with. And if necessary, connect them to other community-based services and supports, to include mobile crisis if necessary. So that is a resource that we're really excited about. When we look at some of the data, we've seen such an increase of calls come in. So the volume there has increased significantly, letting us know that this is a resource that has been valuable and important for people.
I love that. So 911 for, physical emergencies. And our producer, Dave Rivas, was a 911 dispatcher, or 988 is like the suicide hotline, right?
That's right. Yeah, 988.
No, and I love the fact that you are reaching out with new communication messages. And I imagine a younger generation wants to text and chat rather than do the old-fashioned phone calls.
Yeah, and that is what we're seeing, that the text and chat where we've seen the most significant increase in volume.
Right. I love that. And so let's talk about substance use disorder. You have a whole center just for that. You're charged by Congress to help with prevention and treatment for substance use disorder. And what is your main objectives and things that you're working on?
Yeah. So within our Center for Substance Abuse Treatment and Center for Substance Abuse Prevention, so though each of those centers are addressing the substance use challenges that we're seeing. Within our Substance Abuse Center for Substance Abuse Prevention, we have a number of programs really geared towards preventing substance use. We fund many community-based coalitions that do community-based programs, school-based programs, teaching young people and even school personnel about the dangers of substances or how to identify a young person that may be struggling. We have 2 apps that are recent resources that we're really excited about. One is called Talk They Hear You, coming out of, again, the Center for Substance Abuse Prevention. And it's an app geared towards sort of parents or caregivers or even teachers that has really useful information around starting conversations with young people around either their mental health or using substances. There are different vignettes around those conversations and even information and content around connecting young people to services and supports. And then we have a second resource that we called Screen for Success. And that is an app and a website that has information around really screening and being able to identify specific criteria or specific features to look out for to be able to identify a young person that may be struggling. And it has different categories as well of areas of potential concern. So overall wellness or their social connection, things like that. And so both of those resources are coming out of our Center for Substance Abuse Prevention.
That's important, because we know that prevention is really the upstream solution for substance use disorder. And we've done some programs that, teaching emotional resiliency and how to deal with life's challenges without going to drugs. If we get that, then we would have less addiction and problems downstream.
It's so true. It's so true. I mean, I think teaching young people just how to recognize, how to manage their emotions. And if a young person is struggling, getting them connected to services and supports early, all of that makes a difference. In fact, another program that we fund out of our Center for Mental Health Services is called our Project Aware. And it does just that. It's geared towards identifying young people within school settings who may be struggling with mental health or even substance use challenges, and then connecting them with services and support. So it's a program that provides training for teachers and school personnel to be able to identify young folks that may be struggling.
That's great. And we should also encourage the social norms that more people over time more kids are choosing not to use drugs and protect their growing brain. So we should, applaud that and promote those social norms as well.
Yeah, that's true. There is a whole network of young people across the country as part of the recovery work. So there are many different youth recovery organizations that are all about sort of promoting wellness and promoting self-care and promoting, not using substances, again, all across the country that are just wonderful avenues for young people to be connected to and to learn positive, pro-social ways of being a young person.
Yeah. My listeners know that I'm very jealous of infectious diseases. I'm jealous of COVID and monkeypox and the flu. Fentanyl now is plaguing our country more than all of that. And I always wonder, can we apply the same methodology that we do for infectious disease to the issue of fentanyl?
Yeah, it's so true. Fentanyl, we just see it across the country. Increasingly, the overdose rates and patterns that we're seeing, fentanyl is implicated there in terms of being involved and connected to some of those overdoses. And often people don't necessarily know that they're taking it. We find it mixed in, illicitly manufactured fentanyl mixed in with other substances, sometimes with marijuana, sometimes with pressed into pills. And so it certainly is a challenge and a problem across the country. One thing that we're doing there is we have let our grantees know that with our state opioid response grant funds or our tribal opioid response grant funds, and really even our block grant resources, that people can purchase fentanyl test strips. And again, fentanyl test strips are strips that will allow an individual to test their substances to see if there is fentanyl in them. And ultimately that can be life-saving. And then we're also working with states around naloxone saturation. So really working with states to develop plans to saturate their communities with naloxone, such that if an individual is struggling with substances or is overdosing, whether it be with fentanyl or, another opioid, that naloxone is there because we know that is life-saving.
Right. And we're promoting naloxone for anybody who uses any drugs, not just for opioids, because fentanyl has infected the entire drug market and people who are unassuming overdose. I'm really proud. Your funds have trickled down to California, and we're spending that money on naloxone vending machines throughout our county.
Fantastic. Yeah, it's wonderful to hear that those vending machines are popping up. I mean, I was in a conversation earlier today. And the nice thing about the vending machines is that, it will provide easier access. So if a person isn't carrying naloxone themselves, or if they don't have it on themselves, if we can get to a point where the vending machines are available far and wide, then it increases the likelihood that an individual is going to be able to access or get naloxone if they need to help reverse an overdose. So right. I love the idea of the vending machines, and we're certainly encouraging our grantees and others to think about vending machines as well as other sources and avenues for disseminating naloxone far and wide.
Right. And some people are more embarrassed of going to a pharmacy or asking for a prescription because it makes an assumption about what they're doing. So the vending machines are nice. And so, yeah, we're happy to have that.
I do want to mention, naloxone is available over the counter now as well. And so,
and thank you for that too.
Yeah. Again, I so appreciate just the administration's focus. So FDA did approve an over-the-counter version of naloxone that is available or will soon be available if it's not already within pharmacies. And so that's another way, or not pharmacies, but just, within, actually likely in pharmacies, but not necessarily, you don't need a prescription to get it.
Right.
And so that will be another way to be able to help increase access to naloxone, because we know that it is life-saving.
Pick up your Tylenol and Motrin and as well as your naloxone.
Yeah.
And have it we have AED machines, right? Everywhere in different places, public places. We have that readily available as well. Sadly, very sadly that we need such a thing.
Yeah. It is, it's sad that we need such a thing, but I'm grateful that there are those resources available.
Yeah.
The states are working really, really hard to be able to have naloxone available far and wide, putting together really detailed plans. And in fact, later this summer, we're going to be doing a policy academy with states, bringing together state teams to be able to further develop and really get nuanced with their naloxone saturation plans.
Ooh, I have something to share with your state policy thing. Something I'm very proud of that we accomplished in California. We passed a law, Tyler's Law, that requires all hospitals to include fentanyl whenever they order a drug test in the hospital. It doesn't require testing, but if you're going to test for marijuana and cocaine and methamphetamine, why would you not include the number one drug, especially when it's infected in people who are unassuming? And California passed that, and Maryland copied that, and we really hope to get federal solutions for hospitals to include fentanyl in drug testing. It's only 75 cents a test, so I wanted to share that with you. And maybe you can spread the word.
Well, fantastic. And kudos to California for passing that. It's important. And I think testing really is critical to know what substances an individual is struggling with. So it's wonderful to hear that that's the case in California. And it sounds like other states as well.
So you champion for healthcare equity. You've specialized in multicultural healthcare equity. And can you explain to us, what does that mean and where are the gaps that you're finding and what you're doing about that?
Yeah. So, we have quite a lot of work happening in this space. We do have an Office of Behavioral Health Equity that focuses just on this area, on, ensuring that diverse groups and populations, under-resourced groups, whether it be populations of color, LGBTQ individuals, really across the diversity spectrum, to ensure that they have equitable access, so they're able to access services and supports and resources and programs that we offer, but really across the board in healthcare, because we provide quite a bit of training and technical assistance for healthcare providers as well. And so just, some of the things that we do through our Office of Behavioral Health Equity, we do fund, for example, one program or one program that we're implementing right now is called our Disparity Impact Statement. And so for our grantees, what the grantees have to do is develop a statement around how they're going to work with and address any disparity-related populations that they may be serving with that grant. And then we're encouraging that they use the class standards, so the culturally and linguistically appropriate standards that come out of the Office of Minority Health. And ultimately, the goal is to really help to ensure that through that grant, that they're able to meet the needs of diverse groups that they may be serving within that particular grant. So that's one initiative. Another grant that we have or a program that we have is we call our Elevate CBOs. And so what we're doing there is through our NED, which is the National Network to Eliminate Disparities. That includes over 1,500 community-based organizations. And we're working with those organizations around applying for grants. So that's the Elevate CBO initiative. Applying for grants, keeping grants, budgeting, just all the work and data collection, all the work that happens with both applying for and keeping a grant. And so that's one thing we're doing to help to ensure that diverse communities are poised and ready to apply for and access our resources through grants. So those are just two of our initiatives. But, we also fund a number of Center of Excellence, grants that are, for example, we have our African American Center of Excellence. We have a Center of Excellence looking at Latino Americans, Asian Americans, and then also Native American Training and Technical Assistance Center. We have an LGBTQ Technical Assistance Center. So just a range of either technical assistance centers or centers of excellence geared towards addressing equity.
It's good. That's all important because we each individuals relate to different messages, and you accept medical care better, understand it better. Also, if it's coming from an angle that you understand, so that's also important. Let's talk about opiate use disorder and treatment, and I'm sure you're doing a lot about that.
Yeah, absolutely. And so, one of the grants that we fund to address opioid use disorder is our SOAR grant, so State Opioid Response Grant, and then also our TOR grants, Tribal Opioid Response Grants. Those are just, two of the grant programs that we have, very similar, parallel grants. One is for tribal communities in particular, and then the SOAR grant, really goes across the country to states and territories. The thing that what we're seeing there are the states are doing such creative work with the SOAR grant and the TOR grant, so the states and tribes and territories. That grant often will fund just a broad range of prevention, treatment, recovery, and harm reduction services and supports at the community level. So we see things like states funding recovery coaches to work in emergency departments, such that if a person is brought to an emergency department and they've overdosed or they're having some substance related admission, they're connected with a recovery coach. So a person in recovery who then works with them over time to help connect them to services and supports and helps to give them hope by sharing their own story. So that's just one example. And then we also see wonderful mobile vans that go out into communities and disseminate naloxone, or in some instances do low dose induction for individuals that may be struggling with opioid use disorder. So a lot of creativity that is making a real meaningful difference.
I do. I love that. Meeting people where they are. We have that too. We have people going out to the homeless and providing naloxone, and we're going to start buprenorphine treatment and right where people are.
Yeah. And I think that makes a difference because we know that there are some groups, people may not feel comfortable accessing services if they don't understand what they're about, or if they don't know where they are or ways to access them. And so the mobile units, whether it be vans, we've seen in some instances, even RVs that, states are using and communities are using to go into areas that may be hotspots. So areas where there's either high levels of overdose or where they've done previous naloxone dissemination. And it's just an opportunity to connect with people who may not be accessing services and supports or who may not know about services and supports.
Yeah, I love that reach.
That they're planting important seeds for individuals to help them to know about care and how to connect.
So tell us about 42 CFR. Explain, it's a privacy, big law, with fancy numbers, but there are changes to that. Can you explain to us what that is? And I want to ask more about that and how it relates to MAT treatment.
Yeah. So, we did one thing that we're really pleased about was we did put it out for public comment. And we got so many comments related to that. So we really, really appreciate the public feedback and comments related to that.
Tell us what that is. Explain to us what this 42 CFR is and what the comments are. Yeah.
Yeah. So, we are in the process of reviewing the comments currently. So that's something that is currently sort of happening now. But essentially what we do is we put it out, we develop we call it a notice of proposed rulemaking. And what we do is we put that rule out for public comment, and then people will send in, their comments related to the regulation that essentially pertains to, federal opioid use disorder treatment standards. And so that's really what that law does. And what we've done is we have proposed updates to the standards around how people access and experience opioid use disorder treatment. And so really that's what we've gotten some feedback about. We have put in place a number of flexibilities while we're still while we're still synthesizing that information. And so we are, while we're currently synthesizing the information, it put in a number of flexibilities related to OTPs and take-home doses of methadone and medications, just to be able to ensure that some of those flexibilities that we put in place during the pandemic, that people still can access their medications. I mean, ultimately, our goal is to be person-centered, to make sure that we have continued access and increased access, but also to make sure that people have choice even and a voice in the ways in which their information is used or shared as well. And so that's an important piece of that as well.
Interesting. All right, I'll put my little request in for that.
Okay.
Really all into integrating physical health, mental health, and addiction health. It shouldn't be separated. We should be able to talk, each practitioner regarding the field should be able to talk to each other. So if I prescribe as a doctor buprenorphine, it enters our PDMP, state monitoring system. But if the OTP clinics prescribe the same exact medication, they're prevented from reporting. And we really should be talking to each other and sharing information for the betterment of our patients. So that's my request.
Although within the OTPs, the OTP can enter their information into the PDMP and share with the approval of the person. So if the individual that they're working with gives their consent, then their information can both be shared and entered into the PDMP, as allowed by state law, of course, because there are state laws that also regulate some of the sharing of this information. But if the state laws are aligned and if the person gives their consent, then the information can be shared both with other physicians as well as entered within the PDMP.
But see, that's a different standard for those clinics compared to the rest of medical care. We've learned that there shouldn't be, your privacy shouldn't kill you. We should be able to communicate and know, if I'm admitting somebody with appendicitis and they're on methadone, I should know what they're on and their dose.
Yeah. No, that makes sense. That makes sense. The other thing that we are doing with it as well is we're recommending some language changes, because as we talked about earlier, we know language makes a difference. So, changing some of the outdated language like detoxification or detox, and using more and incorporating more updated language. And
what's the new word for detox?
So, instead of detox, it might be, we're looking at different options there. So
withdrawal management?
Could be withdrawal management, but stay tuned. We're still refining all the comments that have come in, but we'll ultimately get there in terms of language that's less stigmatizing, because we know stigma can help to reduce an individual's likelihood of accessing care. And to the extent that people internalize, if an individual internalizes stigmatizing language, it can impact how they feel about themselves. And so with all of these language changes, whether it be through the Part 8 rule or even with our name change, both with SAMHSA overall and within our centers, I'm really looking to have more person-centered, less stigmatizing language, because it does matter and does make
interesting. I always say that, feel bad when I use the language, but I say that to my patients, that maybe you need to detox your body, and to feel better. So I do use that word, so I have to think about that.
Yeah. We all do it. There are language or terms across both the mental health and substance use, field that within our Office of Recovery, in fact, this is one of the areas they're working on in terms of maybe putting out some guidance around language that may be stigmatizing and may be harmful when internalized. Terms like clean, for years that's been used within the substance use related work. Mm-hmm. And what people in recovery tell us is that word is hurtful when they hear, whether they're clean or not, or they've been, but then there are even variations within the field. Like some people say, well, that is, or individuals say, well, I don't mind that term. That's what I've always used. That's what I've heard. Mm-hmm. But in general, we're looking to put out maybe just high level guidance around terms which may be stigmatizing for individuals, and contribute to internalized stigma as well.
Yeah, we do want to promote good self-esteem, right? Congress X the X waiver, yay. So now every doctor in America can prescribe buprenorphine, but there were added educational mandates. Can you explain that? Because medical community is fearful. The whole prescription opioid epidemic happened because of government mandates on prescribing and laws that were passed for that. So now we have new education mandates. Can you tell us about that?
Yeah, absolutely. So with the removal of the X waiver, physicians no longer have to sign up for the specific DEA license or waiver to be able to prescribe buprenorphine. But instead, so physicians or any prescribers, eligible prescribers, so it's not just physicians, nurse practitioners, and other eligible prescribers. Instead, though, what they do have to do is take a one-time 8-hour training. And the training, we are actually working pretty closely with DEA around what the features of those trainings will look like. So stay tuned there. That's in process. We're in regular meetings with them to really be able to outline and work through what that training will look like. But it really will be for new prescribers or for individuals when they update their license. We'll have to take the 8-hour training. And so that's what things are looking like at this point, but we will be putting out and are working really to make sure that prescribers and others have information around what the requirements will be. Since it's a fairly new law that was part of the omnibus bill that came out, ultimately we're still working to get information out and continue to sort of connect with providers on an ongoing basis to keep everyone updated. Because the training requirements have not been put out yet. They're in process, and DEA and SAMHSA and others are working on those now.
So, for example, Champions for Health, which is a foundation arm for the San Diego County Medical Association, worked with San Diego Public Health and created modules and courses on innovation and smart approaches in safe prescribing. Would those courses count, or are you creating a new government mandated course, or there's so many courses out there? Would they all count, do you think?
Yeah, so again, stay tuned, but some of the thinking is it wouldn't be just a government course because there's, missed opportunity there if it's just that. There's a lot of training out there. And so, perhaps, and again, we're still in the process of developing this. It may be that, what is recommended is a particular set of content areas, but that, more broadly, it wouldn't be just one government course that's put out. But stay tuned. We're still working that through with DEA. So I don't want to get ahead of get ahead of the sausage making.
Got it. I will put in a plug for diverse sausages.
Yeah, and we're with you there. Okay. We're with you there because there's a lot of, certainly we know that there are a lot of valuable training, courses and training teams and groups out there. And so we have to all be in this together. And so certainly that's something.
And things change. When I did these courses before, I noticed that from one year to the next, I would have to make some adjustments because there's always something new.
Yeah. The field is dynamic. The field changes, medication changes, treatment protocols change. Right. And so we're going to need, and it's going to be important that the training that's recommended for providers that it's aligned with those changes as well.
I actually, one of the few government people who actually took the 8-hour MAT course, and it left me with more questions, and it wasn't updated on a regular basis. So hopefully we learned from history of not to do that again.
Yeah, and stay tuned because again, it's in process. I don't want to speak before we're done, but my anticipation is that it wouldn't necessarily be one government course.
All right, let's talk about marijuana, something else that needs a lot of education, actually. It can be a controversial topic, but it really shouldn't be when it comes to mental health and addiction, especially our youth. And one of the most, gut-wrenching podcasts I ever did was talking to parents whose children died because of cannabis-induced psychosis. And those parents never knew that, it's just marijuana could be so harmful. My colleague Joe Eberstein, who heads a Marijuana Prevention Institute of San Diego, and his question to you is, what's SAMHSA's position on marijuana, and do you have recommendations for his youth prevention work?
So our position that, we are certainly aligned with the federal government position that, marijuana, we see it as a Schedule 1 controlled substance. We do know when we look at some of the data, young people that are having mental health challenges or they're having prodromal experiences of psychosis. There are some studies that show, that marijuana use can exacerbate those mental health challenges for an individual. It can exacerbate, the experiences of psychosis. There are other studies that show in terms of, again, so individuals younger than 21, that the developing brain, particularly for an individual that is struggling with mental health challenges, can experience adverse outcomes. And so that's certainly something that we're aware of. We're focused again on the prevention, a lot of the prevention aspects of this. So the resource I mentioned earlier, Talk They Hear You, for example, has a lot of examples and resources for parents and caregivers and others around starting conversations with young people around marijuana use or other substances and some of the potential dangers or pitfalls there. So again, I just note that resource because it is quite valuable. And so just wanted to share that again.
We'll include the resources you mentioned in the show notes. So thank you for that. Yeah, so I can't emphasize enough how I see marijuana poisoning every day in my work in the emergency department. I worked last night, patient with cannabis hyperemesis syndrome, cannabis-induced psychosis, cannabis-associated heart problems, every single day. And I don't think people understand or even know that THC is very much more potent than it used to be and has many adverse effects. And we just hear how good it is for, in public billboards, but we're not hearing enough about the harms.
Mm-hmm. Yeah, certainly there are individuals with underlying conditions. There certainly can be exacerbated harms there.
Yeah. So talking about overlap, you know more than anybody that all these things that we've talked about individually with different centers and agencies, they overlap. I see that overlap in the emergency department all the time. People who are suicidal need to, I'm going to use that word you said not to, but need to detox from their alcohol and methamphetamine and marijuana to feel better. So how does SAMHSA deal with the overlap of mental health and addiction?
It's such an important question and definitely an area that we're looking at and really grappling with as well. I'd mentioned earlier our CCBHC grant initiative, so Certified Community Behavioral Health Clinics. One of the things that I really appreciate about that model is that the CCBHCs, and again, there are about 500 of them across the country, and we do have funding to continue to scale those up. That is an integrated model in terms of mental health and substance use. So it provides mental health services, substance use related services, co-occurring services, crisis services as well. And of course does screening for primary care needs and can connect people to primary care services and supports. So we recognize that, people may be struggling with one or the other or both. And as part of our work to create multiple entryways or no wrong door into care, it's been really important to set up models like that. The other thing we're doing, though, is within our grants, within many of our grants, we're letting grantees know that they can propose and think about the grant from a co-occurring perspective. And then we have other grants that are specifically, so a recent reentry grant that we had out earlier this year. It really is to be proposed around both individuals experiencing reentry, but then the programs can be built around mental health challenges, substance use, or co-occurring. So it is an important area to take a look at and continue to provide resources for.
I like that. No wrong door. My other colleague, Marla Kincaid, working for the Center for Community Research, she notes that grant funding goes either to mental health, like NAMI, or to prevention of drugs or treatment of drugs. And these funding divisions sometimes prevent us from working together. So, for example, we wanted to work on suicide prevention, and we noted that the number one drug associated with people who died from suicide, age of the developing brain, 25, is marijuana, by far, much more than alcohol or anything else. We thought, wow, this is a prevention message, not just from the marijuana prevention initiative, but also for NAMI and suicide, and thought, let's work on this together. And it was like, no, we get funding only for this, or we get funding only for that. And it prevented us from working together. Sounded silly to me. What do you think?
Yeah, so we actually do encourage creative collaborations among community groups, and see that we've seen really creative collaborations, across different grantee groups. So I'm not sure which grant that was, but definitely that's something that we are encouraging and actually seeing at the community level. We see sometimes creative collaborations with recovery organizations and either mental health or substance use related organizations, or sometimes even primary care organizations. And we're beginning to see that increasingly. So recovery groups that are working with emergency departments, or recovery organizations working with emergency departments. So we appreciate those types of integrated models, and encourage grantees to do creative community-based collaborations like that.
Great. I love that. I'm going to tell them that you said so.
Yes. And if they have questions, the other thing is if they have questions, certainly contact the project officer that's listed on the grant, or send us an email. Often there'll be a place to sort of send in emails or call. Emails are probably better. Send an email related to any specific question about the requirements for applications.
Thank you. All right. So now we actually got to talk about everything. I want to ask you, what is your most proud accomplishment at SAMHSA? You've listed so many, and I'm going to try to get most of those in our show notes of the various resources. But what's your most proud accomplishment at your time in office here?
That is a very hard question. It's a hard question because, especially now as I'm traveling more now, as the pandemic has gotten better and I can be out and about, and I'm visiting different grantees and community-based programs. And I have to say that's one thing that I am proud of and appreciate seeing, just the real dedication and commitment and hard work that's happening across the country from our grantees, and the just the vision and passion they have for helping people to move into recovery, whether it be mental health recovery or substance use recovery. And we see that across our grants. And it's been wonderful to see that at the community level, the funding that the administration has put forward and that we receive as part of our budget, that it makes a difference. It makes a difference whether we're visiting a SOAR, State Opioid Response Grant, community-based program, or one of the 988 call centers, or one of the Project Aware grants. I've had the opportunity to visit several of those all over the country, and I think that's I'm proud of that for our grantees, and proud of them really for the amazing work that they're doing to help improve people's lives, to help people thrive really. With the challenges that they might be experiencing from a mental health or substance use perspective.
That's awesome. And you know what? It is so, people working in this field are very passionate, and it's infectious. It's nice to be around people who are so passionate about their work and so creative about getting solutions.
Yeah, it really is. It really is. It's energizing. It's energizing, and that energy it can be contagious. So it's a good contagion when people are passionate about the programs, because ultimately I think the people served feel some of that energy and they feel some of that passion. I think it's healing for them as well.
Mm-hmm. That's beautiful. What's your final words of advice for communities across our nation who are working on mental health and addiction?
Yeah, I think my final words of advice would be it's important to have hope. To have hope and reach out to know that if they're struggling or somebody they know is struggling with a mental health or substance use challenge, that support is available, and they don't have to go through whatever they're going through alone. If it's a crisis, they can call or text or chat 988. Or if they're looking to get connected to services, they can look at and look up findsupport.gov. And findsupport.gov is a real valuable resource that can help people to connect to services and supports as well.
That's great. I want to say thank you to Marla Kincaid for your question. And Marla is an amazing facilitator. She is the star of integration of bringing public health, public safety, different community champions from around the area and around our nation together, getting them together, working together. It's an amazing job. Marla is really an example and a champion of that. And thank you so much, Dr. Delphin-Rittmon, for joining us today. We are in good hands with you at the helms of SAMHSA. I really appreciate your leadership and your passion and your time to join us here today at High Truths.
Oh, thank you so much, Dr. Lev. Thank you for having me on.
Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support of our sponsor. A sincere and warm thank you to ISAC, the International Academy on the Science and Impact of Cannabis, doctors educating on the harms of marijuana. Visit isac1.org, that's IASIC1.org, to view their library that translates medical journals for public understanding, listen to their speaker series, and follow the science on marijuana. High Truth producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Oneet Lev. We hope we brought your day a little bit more High Truths.